Well, welcome everyone to the EKG case for the week of May 6th, 2013. This week's case is kind of a continuation of something that we started last week, and it's also a topic that we've kind of addressed a number of times before, but it's worth clarifying some things and updating a few things as well. So we'll start out with this case. This is an 84-year-old man that presented to the emergency department complaining of chest pain and syncope. He's awake now, and this was the 12-lead EKG he presented with when he had chest pain. He's wide awake now, and when you look at this 12-lead, no doubt there's a lot of ischemic findings. There's ST depression in multiple leads throughout the precordium and in the limb leads as well. And hopefully what a lot of people who have been following this video cast over the course of months and even a year and a half now, probably know is that there's one additional thing, that is lead aVR, ST segment elevation in lead aVR. Now, a lot of people don't pay attention to lead aVR, and I hope after watching this you will, if you haven't already. I like referring to lead aVR as the Rodney Dangerfield lead. Many of you remember the famous comedian Rodney Dangerfield, whose calling card was always, "I get no respect." His entire act was based on the concept that he would get no respect. And I jokingly will refer to, I guess as an analogy, if Rodney Dangerfield were a lead on the 12-lead EKG, he would be, of course, lead aVR, because it's the lead that gets no respect. In fact, it gets so little respect, I've heard some cardiologists refer to the EKG as the 11-lead EKG. They specifically have said in the past that there's no point in even taking a look at lead aVR. But if you do look here, you'll notice there's ST elevation lead aVR. For purposes of upcoming discussion, you'll also notice that there's elevation in AVL and in V1, and the ST elevation in aVR is greater than in V1. So keep that in mind as we progress through these slides. All of the things that I'm pointing out are highly predictive of the fact that this patient has a left main coronary artery stenosis. And as we'll talk about, that is really, really bad. All right. So let's first of all start this by talking about what a normal 12-lead EKG should look like. This is a normal 12-lead, and if you pay attention to lead aVR, you'll notice that the ST segment is pretty much isoelectric. That's a normal lead aVR. In fact, sometimes you're allowed to have a little bit of ST segment depression, but if you ever have ST segment elevation in lead aVR, that should really concern you. You shouldn't have ST segment elevation in lead aVR. And if you see elevation in lead aVR, there's a few really concerning things that you should worry about. Now, the first caveat I'm going to give you here is that everything I'm going to talk about only applies to patients that are presenting with ischemic signs and symptoms and ischemia on the 12-lead EKG. If you just run around a conference room, you say you have 100 people in the room, and you just randomly get EKGs on everybody in there who's asymptomatic, you're going to find some people that are not having any problems at all who have elevation in lead aVR. So you don't want to overuse this. Let's say you get an EKG on a person being admitted for cellulitis, and they've got no cardiopulmonary complaints, and you see ST elevation in lead aVR. What does it mean? Nothing. So only apply this discussion to patients who have some concerning symptoms, and when you look at the 12 lead, you look at the other 11 leads, you see abnormalities in those other 11 leads, ST abnormalities, which make you worry about ischemia. Those are the patients that you now need to take a look at lead aVR. And when you see ST segment elevation in lead aVR in those patients, then you've got to worry about some really bad things. So here is what the literature says. When you have ischemic patients with ischemic ST segments, then you take a look at aVR and you see ST elevation. There's one of three things that's probably going on with pretty darn high predictive value and specificity. All right, nothing in EKG, nothing in medicine is 100%, but pretty good here. When you see ST elevation lead aVR in that setting, you're looking at either a left main coronary occlusion, proximal LAD occlusion, or triple vessel disease. All of those are very bad. I think we would agree that if a person's got chest pain or shortness of breath and ST segment depressions elsewhere on the 12 lead, and now you look in aVR and you see that, then any one of these three things is really, really bad. But the worst of all is left main coronary occlusion. These patients have a very, very high morbidity and even mortality, as we'll talk about. All right. Now, we can actually narrow that differential from those three bad things to the one worst of all if we take a look at a couple of additional factors. When you have ST elevation and lead aVR in that setting, there's three things we're worried about. But if there's also elevation in AVL, in other words, ST elevation in aVR plus AVL, then that's very predictive of left main occlusion. Next point, if you have elevation in aVR plus V1, you narrow the differential down to one of these two things, left main or proximal LAD, but we can narrow it even further, and if the elevation in aVR is greater than in V1, then you've narrowed it down to the worst case scenario of all. All right? So, elevation in aVR by itself is bad, but elevation in aVR plus AVL or elevation in aVR greater than in V1 is really, really bad. All right? So we're talking about different degrees of badness. Next question that comes up, how much elevation should you be concerned about? And this is oftentimes an issue that comes up in our ED, and people will email cases. And some of the literature out there will actually indicate that if you have as little as a 0.5 millimeter of elevation in aVR, it's predictive of badness that we've talked about. Other literature points more towards 1 millimeter. There's some literature actually saying if it's 1.5 millimeters or more, then it's really bad, and there's actually an increased mortality over what we'll talk about in just a little bit. Nobody's really come out and done good research to try to figure out what the actual cutoff is, which will maximize your sensitivity and specificity. But I'm going to tell you that what I do, and this is just my personal practice based on kind of a combination of what I've read and what I've seen in practice, what I worry about is 1 millimeter or more. All right. So when somebody's got ST elevation to AVR of at least 1 millimeter, then that's when I really start worrying about AVR, because a 0.5 millimeter, despite what some of the literature says, is a bit too non-specific for me. So the first thing, this is just my personal practice, I worry when they're at 1 millimeter of elevation or more. All right. So that's one question that comes up. I figured we'll just answer that question right up front. Now, your cardiologist may not know about this literature, and that's not a slam against the cardiologist. They've got a lot of different subspecialties within cardiology, and whether your cardiologist knows about this or not, really it's going to depend on whether that's the kind of cardiologist who loves reading about EKGs. Not all of them do. So here's the literature that you'll need to share with your cardiologist to educate them a little bit. All right? Google. You can just go to Google, for gosh sakes. You can just Google search this and you will find literature on this topic. All right. If you want to go to PubMed or Medline or some real medical sources, there's stuff in the emergency medicine literature. There's cardiology literature. This article, by the way, if you are a U.S. board certified emergency physician, you will be reading this article. This is now part of the LLSA set of readings, mandatory reading for all boarded emergency physicians in the U.S. Ivan Rokos, who's an emergency physician out in California, teamed up with a group of very, very well-known cardiologists, and I got a chance to be involved in that publication as well. And what we did was we talked about a handful of different EKG findings, which we are proposing should indicate that they are appropriate reasons to activate the cath lab, and ST elevation lead AVR is one of those indications based on the literature we've seen. Now, this is not yet part of national guidelines, but there's a lot of cardiologists out there already who will take these patients right to the cath lab, and there's more and more and more and more and more literature coming out saying that we need to really worry about this, and in fact should probably push these patients to the cath lab. Again, it's not part of the national guidelines, but hopefully in the coming years it will be. Here's some more cardiology literature. Nikas, who's a well-known, world-renowned cardiologist who publishes a lot of really great EKG stuff. And then these are two articles that are pretty interesting, both from the cardiology literature. In these two articles, these two separate authors both were so concerned about lead aVR that they actually said that if you see ST segment elevation in lead aVR, don't give the patient clopidogrel. Why would that be? It's because if you have elevation in lead aVR, they say that it is so predictive of left main, which in and of itself is so often in need of bypass surgery, that they said if you see elevation in lead aVR, just assume that there's such a good chance that patient's going to need bypass surgery for left main. Don't give clopidogrel, because we don't want to give clopidogrel to patients that are going to end up getting bypass. So these are two interesting studies that believe so much in this aVR elevation that they actually say, plan on the patient going for bypass and stay away from clopidogrel in those patients. Here's another article by Nickus, again, Palm, Galen Wagner, who's now the main editor of the famous Marriott textbook. And look, I'm even going to give you some page numbers that you can share with your cardiologist. This is an international paper. Here's another paper by, again, Nickus, Palm, Wagner. This is a Third International Society for Holter and Non-Invasive Electrocardiology. Sounds pretty good, right? There's the page number in case you need to share that with your cardiologist. Here's another one. This is from the two biggest journals in cardiology in the world, probably. Circulation, which is the main journal of the American Heart Association, and Journal of American College of Cardiology, which is the official journal of the American College of Cardiology. Every handful of years, they revise their recommendations for how we are supposed to read the EKG. There's your page numbers if you're online or in print. There's your page numbers that talk about lead aVR and its concerns for left main coronary artery occlusion. Now, why do we have to worry about lead aVR in the first place? It's because if somebody has an occluded left main coronary artery in an acute ACS, in acute coronary syndrome, those patients, according to some literature, have a 70% chance to going on to develop cardiogenic shock and even dying unless they get invasive therapy, and medical therapy doesn't seem to work. These patients really need invasive therapy as soon as possible, and time delay to PCI, according to some literature, is the only predictor of survival. If you do move quickly, you'll drop that mortality from 70 down to 40%. 40% is still pretty bad, but it's a whole lot better than 70%. So try to get these patients off to invasive therapy as quickly as possible, according to the literature that's out there and according to our recommendations in that paper that we published in American Heart Journal. All right, so let me show you a few examples here just to really hammer home this point. This patient is actually having a STEMI, ST elevation V1 and V2. And there's multiple reciprocal ST depressions, and now we're going to look up here, and there's elevation aVR and AVL. What does that mean? It's left main. This was my patient a number of years ago when I was working at a community hospital. All we had was thrombolytics. I gave this patient thrombolytics. Despite the thrombolytics, the patient went on to develop cardiogenic shock and die within about 12 hours or so. Had I known back then what I know now, I would not have bothered with thrombolytics, because the literature says medical therapy does not work. If I had known what I know now, I would have gotten on the phone and sent this patient somewhere for cath. The thrombolytics did not work. Almost identical scenario in this case. Patient's having, once again, an anteroseptal STEMI. And so we'll look up here. And there's ST elevation in aVR greater than in V1. Excuse me. ST elevation in aVR is also greater than 1.5 millimeters. Same exact story. I gave this patient thrombolytics. The patient developed cardiogenic shock and died in about 8 to 12 hours. Had I known back then what I know now, I would not have bothered with thrombolytics. I would have gotten this patient on an ambulance and sent him as quickly as possible to a cath center, found a receiving cardiologist, and shipped him out. But I didn't know about this back then. I thought thrombolytics were the way to go. Here's another scenario. This patient's having a septal STEMI, and this patient, and now look up in aVR and AVL, that's left main. This patient did go for immediate cath, unfortunately died on the cath lab table. Here's another patient. This patient is having an inferior wall STEMI, But there's ST changes, so what are we going to do? We're going to look in aVR, and there's elevation in aVR, which is greater than the elevation in V1. That means left main. And this patient ended up going for cath and survived. We had a left main lesion, ended up getting bypass surgery. Here's a 78-year-old guy who is having some atypical symptoms. You know, you can't trust those elderly patients to have classic symptoms, can you? There's a lot of ST depression everywhere, so now we're going to look up in aVR, and there's elevation in aVR greater than in V1. That turned out to be a left main lesion. He went to the cath lab and ended up doing okay with invasive therapy. This is a young patient who has a lot of ST segment changes, and so what we're going to do is look up in aVR. There's elevation in aVR and AVL, and elevation in aVR greater than in V1. That's kind of a close call. But definitely aVR and AVL, that means left main. He ended up on a balloon pump in cardiogenic shock after his cath, but ended up surviving. Hopefully you're getting bored of these. I really do want you to get bored of these. I want you to know this so inside and out that you never miss this. And so it's not my concern if you're going to get bored of it. You've got to know this stuff really, really well, right? There's a lot of ST depressions up here, so you look in aVR. There's elevation in aVR greater than in V1, and this patient ended up having a left main. This patient actually was at a community site and unfortunately didn't get transferred for about 6 hours, went into cardiogenic shock, and went to the cath lab, but died on the cath lab table. And you just wonder whether those 6 hours of delay ended up costing this patient his life. Here's another patient, and again, you probably are bored of this and know exactly what's going on. There's ST depressions in the limb leads and in a couple of the anterior leads, so we're going to look up there in aVR, and there's elevation in aVR and AVL, so we're done, right? This is left main, and this patient ended up surviving, and I think had a bypass. And this is sent to me by a paramedic, Chris Tuzo. Same story, ST depression in multiple leads, so we're going to look up there in aVR, and there's elevation greater than in V1. That was a left main occlusion. Patient ended up doing okay. Now, I've talked a lot about elevation in aVR, predictive of left main. It's important to know that just like with every other EKG abnormality, there can be some normal variance. And this is one example of a normal variant. Here's a patient that presents with an SVT, and you'll notice that there's ST depressions in a bunch of leads, which we know in the presence of an SVT, ST depressions are not predictive of anything. But you may notice that there's elevation in aVR, and when there's elevation in aVR in the presence of an SVT, it means nothing, all right? So, key point here is that you can have ST elevation in aVR in the setting of an SVT, and I've seen this in rapid AFib as well, and as long as it goes away after the patient converts, or in the AFib case, after the patient's heart rate comes down, as long as the ST elevation in aVR goes away, it is not predictive of badness. It's just the normal variant, okay? And the case I kind of teased people with last week, this is the EKG that I showed you last week. You'll notice there's really concerning elevation in aVR. There's a lot of ST segment abnormalities up here as well. This was a learning case to me. This was just actually a couple of months ago. Patient came in with atypical chest pain and was extremely hypertensive. A non-compliant patient, but was extremely hypertensive. We called up the cardiologist and said there's significant elevation in lead aVR. Now, this cardiologist that we spoke to knew about aVR, but when we told him that the patient's blood pressure was 240/140, he taught me something. He said that when a patient has really significantly elevated blood pressure, sometimes that in and of itself can produce ischemic changes. So what he said was get the patient's blood pressure down to a reasonable number, not normal, but just to a reasonable number, and repeat the 12 lead. If the ST elevation in aVR continues to look really bad, we'll go to the cath lab. But if the ST elevation in aVR looks a lot better, then we'll presume that it was just severe hypertensive induced stress on the heart. Well, I'd never heard of that before, so I went ahead and we did that. We got the patient's blood pressure down. Actually, a couple of my colleagues were caring for this patient. They got the blood pressure down, And sure enough, the ST elevation aVR, along with the rest of the ST changes, got a whole lot better. And so we simply admitted the patient, got some cardiac enzymes, we spoke with the cardiologist, and the patient ended up doing okay. So that was a learning experience for me. I had not heard that before, and I did a little reading about that afterwards, and sure enough, there is actually some literature saying that severe elevated blood pressure can induce that aVR finding. And this is especially common. Let me go back to this case. This is especially common in patients that have really, really bad LVH. Take a look at this. This patient's got big time LVH, right? Big QRS complexes all over the place. Patients with severe LVH and concurrent severely elevated blood pressure can manifest this abnormality and lead to aVR, and that can be a normal finding. Get the blood pressure down, and if it goes away, it's probably fine. If the elevation aVR persists, then you'd probably need to worry about that. All right. Now, this was again a new learning experience for me, so I was happy to learn about that. Okay. So LVH, this patient's got LVH with strain. There's ST segment sagging. It's kind of slanted downwards. That's a strain pattern in those lateral leads. And in the presence of severe hypertension, they can sometimes develop that aVR. So get the blood pressure down and repeat the 12 lead and see what it looks like afterwards. And oftentimes it'll go away. Going back to the original case, the original patient has some degree of LVH as well. It's not nearly as bad. But the reason you'd need to worry about this patient for sure, number one, the blood pressure is okay. So you can't use severe hypertension as an excuse for this. And then the other thing that you'll notice is pretty much everywhere you see ST segment depression, see the horizontal ST segment depression ought to really make you concerned. These could be strain patterns, but when you see the horizontal pattern in so many leads, that's got to make you concerned for true ischemia. All right. So strain pattern will give you slanted downwards ST segment depression, but true ischemia tends to give you horizontal or even sloping upwards ST segment depression. So that might be helpful as well. And again, as I mentioned, the blood pressure here was perfectly okay. So let's sum things up. Once again, when you've got a patient who's got ischemic ST segments and is having concerning symptoms, then look for that lead aVR. This does not apply to SVTs. It probably doesn't apply to rapid AFib. It also doesn't apply to asymptomatic patients or patients without ST changes. All right. So these are concerning chest pain patients that have ST abnormalities in other leads. Now what you do is look in aVR, and that will make you concerned for left main. All right. It can be a normal variant in left bundle. We didn't talk about that, but it can be found in left bundle, and also severe LVH when there is severe hypertension. Usually, by the way, these patients with severe LVH will have significant QRS widening. All right. So take-home points once again. Beware ST elevation in aVR in ACS patients that have ST changes consistent with ischemia. And if you just see aVR, there's 3 possibilities. But of course, if it's aVR plus AVL, there's 1 possibility. If it's aVR greater than in V1, there's 1 possibility. And these patients tend to do best with invasive therapy. So that is the scoop on left main until I read more and find out more about it. And also take that literature that I pointed out and share that with your cardiologist if they're not believers in this concerning ST elevation in aVR. It's all over their literature, and I only showed you a few articles from the past couple of years. If you go back a decade, there's dozens of articles that talk about this particular abnormality, and the literature is getting better and more replete. So make sure that your cardiologists know about this stuff. All right. So I hope that clarified a lot of the questions that have been coming in about ST elevation in aVR. And I'd love to keep getting these cases. So share the cases. If you have these, go ahead and send them on in. I hope that was helpful. And I look forward to talking to all of you next week. Bye for now.